Hello everyone. Today's video is the second part of IEM key points. Lysosomal storage disorders, sphingolipidosis. So the ones in this category are GM1 and GM2 gangliosidosis. GM1 is the deficiency of beta galactosidase, and GM2, there are two types in it. First is Tay-Sachs disease, which is deficiency of hexosaminidase A enzyme, and the second is Sandhoff disease, which is hexosaminidase B enzyme. Glycogenosis type 2. So Pompe disease, which is also classified as glycogen storage disorder type 2. It is also a lysosomal storage disorder. Pompe disease, there is deficiency of alpha 1,4 glucosidase enzyme. Mucopolysaccharidosis, MPS type 1 is Hurler syndrome, and it is because of the deficiency of alpha L iduronidase enzyme. And mucopolysaccharidosis type 2 is Hunter syndrome, and it is due to deficiency of iduronate sulfatase enzyme. Now Shy syndrome, which is also called as MPS 1S, it is the attenuated form of the Hurler syndrome. Now Hurler syndrome is the severe form of MPS 1, whereas Shy syndrome is the attenuated form of MPS type 1. So if you are given the enzymes, you should mark alpha L iduronidase as the deficient enzyme in MPS type 1 and in MPS 1S as well. Specific enzyme is sulfo-iduronate sulfatase. Now sulfatidosis, metachromatic leukodystrophy, the enzyme deficient is aryl sulfatase A. Krabbe disease, the enzyme deficiency is galactosyl ceramidase. Gaucher disease, glucocerebrosidase. Fabry disease, alpha galactosidase A. Niemann-Pick disease, sphingomyelinase. Wolman disease, the enzyme deficient is acid lipase. All lysosomal disorders are autosomal recessive except Hunter and Fabry disease. These two are X-linked recessive. Hunter syndrome and Fabry disease, these two are X-linked recessive disorders, whereas all the other lysosomal disorders are autosomal recessive. This is important. Now neurodegenerative disorders, white matter disease and gray matter disease. White matter disease, Krabbe disease, Alexander disease, Canavan disease and metachromatic leukodystrophy. This you can remember as Kohli, Anushka, can meet. Okay, so that is K, A, C and M. Krabbe disease, Alexander disease, Canavan disease and metachromatic leukodystrophy. And here gray matter disease, Menke disease, Wilson disease, Leigh syndrome and Tay-Sachs disease. This you can remember as most women love tea. Okay, so this is the mnemonic for this. So white matter disease are Krabbe disease, Alexander disease, Canavan and metachromatic leukodystrophy. Gray matter disease are Menke, Wilson, Leigh syndrome and Tay-Sachs disease. Okay, so first one is Krabbe disease. It mainly affects the white matter of the brain. There are globoid bodies in the white matter. The inheritance is autosomal recessive. The deficient enzyme is beta galactosidase. More appropriately, galactocerebroside beta galactosidase deficiency. Clinical features are optic atrophy, spasticity, microcephaly, bilateral symmetrical basal ganglia, hyperintensities in the thalamus. Now this is important. Okay, most IEMs, when you get it as a case scenario, there will be some clue in the question which is specific to that particular disorder. So hyperintensities in the basal ganglia in the thalamus predominantly, along with the other features that it is a white matter disorder, beta-galactosidase deficiency and microcephaly particularly. This should all point towards Krabbe disease. So remember that most other leukodystrophies like Alexander and Canavan, those two are associated with macrocephaly, and metachromatic leukodystrophy, the head may be normal, circumference may be normal. Krabbe disease is particularly associated with microcephaly and basal ganglia hyperintensities, that is in the thalamus. Alexander disease, the incidence is sporadic and macrocephaly may be associated with this disorder. The typical finding here in the brain is Rosenthal fibers, and the diagnosis depends on the brain biopsy. Now these Rosenthal fibers you can see over here in this picture. These pink ones, these are the Rosenthal fibers. They are also seen in other disorders of the brain like medulloblastoma and all. But if they are seen in the white matter, widespread Rosenthal fibers in the white matter of the brain, that should point towards as Alexander disease. Also subcortical U fibers, and it is prominent in the frontal lobes. This again is an important clue towards Alexander disease. There is mutation in the GFAP gene, which is the glial fibrillary acidic protein. Canavan disease, there is deficiency of aspartoacylase enzyme. There is accumulation of NAA, that is N-acetyl aspartic acid in the brain. The typical triad, this is a question asked previously, the typical triad is hypotonia, head lag and macrocephaly. This is seen in Canavan disease. And urinary and blood levels of N-acetyl aspartic acid are increased. That is a part of diagnostic workup. Metachromatic leukodystrophy, autosomal recessive inheritance, chromosome 22q involvement, deficiency of aryl sulfatase A enzyme, there is gene mutation, ARSA gene mutation, there is accumulation of cerebroside sulfate in the myelin sheath, and the typical pattern on imaging is the stripe sign or the tigroid pattern. Like you can see, this is the tigroid pattern or stripe sign seen on the imaging. This is a spotter question, and this is also a clue in the case scenario. This points towards metachromatic leukodystrophy. Clinical features are gait disturbance, neuroregression, optic atrophy, and a mix of UMN and LMN signs. Adrenoleukodystrophy, remember this is X-linked. This is not autosomal recessive. This is X-linked, and there is deficiency of acyl-CoA synthetase. The clinical features are ataxia, spasticity, motor deficits, and cortical blindness. And macrocephaly may or may not be present. Now gray matter disorders, the first one we saw is Menke disease. This is X-linked recessive disorder. There is a defect in the transmembrane copper transport, and there is mutation of the ATP7A gene. The copper level in the brain and liver is low in this disorder, and on MR spectroscopy you will find lactate peak. Clinical features, this is a typical question. There is delayed dentition, Wormian bones, multiple fractures, flaring of ribs, and kinky hair. This is a case scenario like question that will be asked. So every line on this slide is a question in itself. Wilson disease or hepatolenticular degeneration. This is autosomal recessive. There is mutation in the gene ATP7B. Chromosome involved is 13q14. 13q is what you need to remember. There is decrease in biliary copper excretion, and therefore there is copper accumulation. There is decrease in serum ceruloplasmin levels, which is less than 0.2 gram per liter. Urine copper excretion of 100 microgram per 24 hours, and liver tissue 250 mg per gram of dry weight. This is diagnostic on liver biopsy. However, because of genetic workup, the genetics itself may be considered diagnostic. The reference for this is PubMed. There's a PubMed article on this. Clinical features, there's asymptomatic hepatomegaly, subacute or chronic hepatitis, acute hepatic failure, portal hypertension, ascites, variceal bleed, tremors, dystonia and behavioral changes. Now remember that the patient may have an absolutely normal LFT despite having chronic hepatitis. So a normal LFT does not rule out a chronic liver disease. Brownish deposits in Descemet's membrane in the cornea. This is the KF ring. This is also again diagnostic feature of Wilson disease. And Coombs negative hemolytic anemia. This is a question. So this is the KF ring, this brownish ring around the cornea. Okay, there is deposition in the Descemet's membrane. Leigh syndrome, this is a mitochondrial disease. The typical symptoms are psychomotor retardation, seizures, ophthalmoparesis, nystagmus, optic atrophy, ataxia, dystonia and respiratory problems, and this is a fatal disease with no cure. And the last one is Tay-Sachs disease. This is autosomal recessive. There is deficiency of hexosaminidase A enzyme. There are 3 forms. Infantile form is the most severe. The juvenile and adult forms are gradual. Infantile form, it occurs in 3 to 6 months of age. There is exaggerated startle response, which is basically auditory myoclonus. This is very typical of Tay-Sachs disease. If this is there in the question, you have to mark Tay-Sachs disease as your answer. Other features are optic atrophy, nystagmus, myoclonic seizures and spasticity. And unlike many other IEMs, hepatosplenomegaly is typically absent in Tay-Sachs disease. So remember, this can be a differentiating feature. Hepatosplenomegaly is typically absent in Tay-Sachs disease. Wolman disease, this is an autosomal recessive disease. This is a lipid storage disorder due to mutation in the LIPA gene. The enzyme deficient is acid lipase enzyme. There is accumulation of triglycerides and cholesterol esters. These lipids are deposited in the spleen, liver, bone marrow, small intestine, adrenals and lymph nodes. There is calcification of adrenal glands along the cortex, and the diagnosis is finding the deficient enzyme in leukocytes. There is deficiency of this acid lipase enzyme in the leukocytes, and also prenatally it can be diagnosed through amniocentesis. Now again, every line in this slide is important. Calcification of adrenal glands, this has been asked before, and this has been also covered in one of my previous videos. So that's all for today guys. Stay tuned for next videos.